The Positive Pause is a motivational-minded podcast covering topics women want to know about as they journey to and through menopause, focusing on subjects that impact women's health and healthy aging, including what it means to age healthfully. The Positive Pause features experts and influencers from a variety of industries and specialties. The information and opinions expressed on the Positive Pause are not intended to replace the services of trained professionals or to provide specific medical advice. To see the National Menopause Foundation's full medical disclaimer, please visit nationalmenopausefoundation.org.
Hello and welcome to The Positive Pause. I'm Claire Gill, founder of the National Menopause Foundation. Joining me for this episode is Dr. Samantha Dunham, a board-certified obstetrician-gynecologist, certified menopause practitioner, co-director of the Center for Midlife Health and Menopause at NYU Langone Health, and clinical associate professor in the Department of Obstetrics and Gynecology at NYU Grossman School of Medicine. She practices general gynecology and preventative women's health with a special focus on perimenopause and menopause and the role they play in disease development. At the Center for Midlife Health and Menopause, she educates patients on what to expect through perimenopause and menopause and partners with them to develop a treatment plan that aligns with their symptoms and goals for treatment. Dr. Dunham received her MD at Temple University and completed her residency in obstetrics and gynecology at New York University and has been a board-certified physician for NYU Langone Health since 2006. Thank you so much for speaking to me today, Dr. Dunham.
Thank you so much, Claire, for having me today. I really appreciate the opportunity to talk about perimenopause and menopause.
It is such an important topic, and I've talked on this podcast before about really the crisis in midlife healthcare that women face in the U.S. You and your fellow clinicians who are certified and trained in menopause care are absolutely essential, but it's impossible for you to be able to reach and care for the millions of women going through the menopausal journey. So I'm really curious about what led you from OBGYN practice, again, which is our reproductive time, into becoming certified as a menopause practitioner.
Mm-hmm. Fortunately, I trained at a program where there was an emphasis on menopause education. So I was sort of familiar with what menopause symptoms were like and what treatment options were. And this was back in the early 2000s. And then in my first kind of job as an attending, I worked with an older doctor who had been treating menopausal women for years. So I sort of had an apprenticeship with him, and it gave me a really good handle on options for menopause treatment. And this is about the time the WHI came out. So I was like pre-WHI, familiar with options for menopausal treatment. And then I practiced on my own. I joined faculty here at NYU Langone and worked as an OBGYN, and then kind of transitioned into gynecology only. And sort of over that time, like over the 10, then 15 years, I was just practicing gynecology and actually, experiencing my own menopause transition. I really recognized this gap in the care for women of this age.
Yeah.
I learned, I think, as much from my patients and their stories and listening to them, and also from other practitioners working with hearing their stories, and really kind of tuned in to the problem of menopausal women just not having a place to go. So I became certified as a menopause practitioner, and it was just a way to go deeper into the field and also to identify myself to patients that this was a special interest of mine. So, the Menopause Society certifies practitioners, and they provide a ton of resources, and they're just a great option for both patient information and practitioner information.
Yeah, we spend a lot of time on this podcast directing women and listeners to the menopause.org, which is the Menopause Society website, because they do have a list of practitioners who have completed certification. And that's really a great place for women to start if they're looking for someone who has that specialty. But it's really important that clinicians like you start looking at that within your own practice and thinking, wow, there's this incredible gap. And what do I do? And how do we provide that care? Because it's a really complicated time of life, given the onset of so many other diseases. When you think about sort of holistic midlife healthcare for women, and when you create that menopause center that you work at. What does that encompass? What are you looking at, and what are you kind of supporting women at within that practice?
Sure. So yeah, in our clinic, I mean, we see patients, I mean, there's kind of like two areas. People come in with symptoms and really need guidance on what they can do about their symptoms. And they want to hear about options and treatments. And then people come in also asking about like kind of anticipation of what to expect. So we kind of provide holistic care in the sense of addressing symptoms, but also kind of pushing beyond the symptoms, like looking at nutrition and diet. We look at exercise and fitness. The symptoms vary, right? Symptoms for everybody really are individual. So it depends on the person's initial, like what their main issues are. I mean, sometimes it's mood related things. Sometimes it's sleep related things. There's a variety of physical symptoms that you're probably familiar with, like the hot flashes and night sweats. Joint aches are huge. And then change in libido, weight gain. I mean, it's a very long list, as you've seen. So we address, where the main problems are and try to kind of push out to explore what we can do to help.
Yeah. Well, it's interesting though, because again, since you have that focus on menopause and that center to go to, so many women talk about the fact that when they're having, for example, joint pain, or if they're having sleep disturbances or things like that, they actually get sent to a million different directions looking for a cause, right?
So true. Yeah. And for some things, I mean, for example, like heart palpitations are not uncommon when estrogen levels start to change. So for those sorts of problems, it's right, totally correct to go see your primary care and maybe see a cardiologist if it's a new problem. But a lot of things can, when they're identified as menopausal or menopausal related, like transition related, I think it gives people a sense of calm, or reassurance that it's just part of what's happening and that there's not something inherently wrong. Like it's not a harbinger of further disease. It's really just a symptom of their perimenopause. And then we give them options on how to deal with the symptoms.
Yeah. I mean, that's true because one, you have to make sure that it's not caused by something else more serious, but women don't know enough about what to expect to, realize that, oh, wow, if I'm having sleep disturbances and I'm having heart palpitations and I'm skipping periods, that would be, that maybe I should talk about menopause, but women don't know about that. We only know about, I might have a hot flash, and other, some people don't experience the hot flash, so they don't realize some of these other symptoms are related to that journey. So we have so much education and things to do. I'm curious to talk a little bit about how that menopausal journey is diagnosed. So I mentioned when we were talking earlier that I was on Capitol Hill recently for Menstrual Health Month and the Menstrual Health Act that was being brought forward. And one of the things that came up when I was thinking about what to share during that session about women's menstrual health as we start the journey was how menopause is diagnosed. And one of the things that came up was it's sort of a diagnosis of elimination.
Of exclusion, exactly.
Yeah, exclusion. Can you talk about that? Yeah. How that kind of comes about?
So it depends on when it's happening. So the average age of menopause, is 52, and 95% of women have menopause between ages 45 and 55. So, somebody comes in with skipping cycles for several months and symptomatic, and they're between the ages of 45 and 55. We don't need blood work to confirm they're menopausal. So it really is a clinical diagnosis at that point. When people are younger, like less than 45, and they they have symptoms and the same kind of presentation, in that case, we would do blood work to rule out other things like thyroid disorder or prolactin disorder or something else that could give them irregular periods. So that's sort of how the diagnosis is made. It's really a clinical diagnosis.
Yeah. And I know we actually have partnered with Clear Blue on some of the educational things that they're doing. And they have a new menopause diagnostic kit, indicator kit. And part of that conversation was you can't determined just on FSH levels, whether or not
Mhm.
a woman is having
Yes. Mhm.
menopause. It really is about a clinical diagnosis. But what we liked about that particular product, and we're like, okay, we'll help raise awareness, was the app that goes with it takes you through all of the other things to jot down your symptoms and to check your cycle and do all of that kind of stuff to then bring to a clinician who, in most cases, is not an expert on menopause as you are, so that they can say, without being dismissed, here's what I'm experiencing across all of these different things. Can we talk about what this might mean? And it's so different for every woman. I share all the time that I was, again, a later mom. So I had my daughter when I was almost 42. And within a year, I started missing cycles and, started thinking this. And I go to my doctor thinking, oh my God, I'm pregnant, right? Am I having another baby? And then it was, blood to work and sort of putting pieces together was like, oh no, you're probably, you're perimenopausal. And I'm like, I just had a baby. So it's so confusing for
Part of
women
perimenopause,
sometimes, right?
right?
How is this
What a,
possible? When we think, like you said,
what a roller coaster.
we think about 52, and I'm not
Yes.
even there yet. I've got plenty of time. But that is so important for women to be able to pull those pieces together and make sure they talk to their doctor about it. Because, like you said, it could be many other things, fibroids or, thyroid or all these other things. Or it could just be, this is your time that you're starting this journey.
Right. And the journey is, we don't know how long the journey is. I mean, the menopause is just when the period stops, but there's a long time before that point when people are very symptomatic. And even when their periods shift, not even skip, but just shift. So by some 7-day interval, they're coming at a different time frame, like the cycles become longer or shorter. And that's the beginning of perimenopause. So some people can have symptoms during that time too. I love your point about keeping track and keeping a journal, because that's, I think, the most powerful tool a patient has for themselves. When they go to a practitioner's office, they can advocate for themselves using that tool. We're also pressed for time. And there are these like 15, 20-minute visits that you're supposed to cover so many things. You really have to cover a lot. But I think if somebody's concerned that they might not be heard during the visit, to make a separate appointment just to talk about those symptoms and really dedicate it to what's happening and use the time wisely. It's definitely not like an afterthought conversation. It has to be the conversation if you want an answer.
That is so important. That's something I learned from talking to all fabulous clinicians in this space, is that we often do that as women. We go in for a well women visit or your pap smear or whatever it is that you were scheduled for. And then as the doctor is walking out the door, say, I've been having hot flashes or things like that. It can't be that afterthought, as you said. And I also think it's important because women don't even know that if you have had your annual exam and, completed it and didn't have a chance to talk about any issues, it is okay to schedule another appointment
We
specifically.
want you to. Yes, absolutely.
Yeah. We're not even told that that's something we can do. And so, and that again, doctors would welcome the conversation if, again, it was scheduled at another time and be able to devote the whole meeting time to whatever those symptoms are that you're having that you have questions about. Yeah, really important.
Mm-hmm.
So you mentioned a little bit about joint pain being really common. Are there questions that you get all the time from women? Like, what are the main topical questions that you get from women when they're coming to find out about this menopausal journey?
The big question seems to be, how long is it going to last? People want to know, like, how long am I going to feel like this, or what's going to happen next? And I think some of the kind of consternation around menopause is that unpredictability is there. Where women are used to having regular cycles throughout their life. And when that stops and there's chaos, ovulatory chaos, and then you find out you're having symptoms, you don't know when that's going to stop. It's really hard to deal with. So I think part of the anticipatory guidance that we give is that it is unpredictable and we can support you through it. And we can give you a general time frame. Like, we know that symptoms vary according to kind of like ethnicity. And then there's something to do with genetics as well, like depending on how your mother experienced menopause, or your sister maybe would be a better example about how they experienced menopause. That would come into play. But it's very unpredictable. But we can give some people general ideas. Women learn that, especially like that, it could be 7 years, 10 years for Black women, around 7 years over average. That's when they really listen to well, what can I do about it? They can't imagine themselves living for 5 years in this situation. So really, what can I do about it? So that, I think, is one of the most common questions.
Yeah.
And then people also ask, do I need to take hormones? Because there's so much talk now in the media and social media about hormones as a solution.
Mm-hmm.
And so a lot of people want to know if they should take them if they don't have symptoms, or if they have mild symptoms, should they take them? And, that's another big topic of conversation.
Yeah. And it's really, again, it has been so confusing with the science that we had coming out of the Women's Health Initiative 20 years ago, which basically had said there was a high risk for heart disease and breast cancer for those who were taking hormone replacement therapies. And I think both women and providers just completely stopped. That was it, done.
Right.
Again, why would you take that risk? And then, talking through now that what we know now about how that study, the limitations of the study and how it was conducted, and that risk is really not there for women when they take it at hormone replacement therapy at the onset of their symptoms versus 10 years after their last period. And so those are the kinds of things that can become confusing for both sides of the equation. I hear from women all the time that their provider will not prescribe hormone replacement therapy because of what they know from past studies. And so we have a big education gap to go through from both the consumer side and the provider side on what does the current science say about hormone replacement therapy. But if women, so like I said, some women are agreeable to it and realize that really it is incredibly effective treatment, and it has other benefits as well for women, protecting a bone, et cetera, to consider what now we call, I guess, menopause or hormone replacement therapy is an option. But what are there things that women can do that are not pharmaceutical?
Yeah. So we talk about all the options. We talk about hormone therapy, we talk about non-hormonal therapy, and we also talk about complementary therapy. Like an example of complementary therapy would be cognitive behavioral therapy, which has been shown to work for managing hot flashes and night sweats, so vasomotor symptoms. Also, hypnosis, interestingly, is also proven as a technique to help with hypnosis. Weight loss is also effective for, these are all dealing with vasomotor symptoms.
Yeah.
And then we talk about non-hormonal things like, there's SSRIs and SNRIs. A class is FDA approved, and we use to help with, for some women who can't take hormones, like they've had a diagnosis of breast cancer, for example, and they can't take hormones in at least the immediate and near future. So they would be offered something like a non-hormonal option, like an SSRI or SNRI. And those are effective as well. They're not as effective. They're like the excellent treatment that hormones provide.
And can you explain what the SSRI is?
So Paxil is the SSRI, or paroxetine, but we use SNRIs as well, like venlafaxine, which is Effexor, and also Pristiq. So a variety. So sometimes people are taking those for other reasons, and maybe they have a little less hot flashes as a result.
Yeah.
But the non-hormonals can be associated with some other side effects that they have to be aware of. But it's a full discussion. We really run the gamut of options and figure out which one they're most comfortable with, because everyone comes to us with their own kind of like educational foundation and health literacy, and there's cultural sensitivities, and we don't want to create more anxiety in someone's life. Like, we want to kind of improve their overall well-being.
Yes.
So
I think that's what's so important too, is just making sure that women know that there are options, that there's suffering in silence isn't necessary, because there are great things that can be done to help. And just being able to find someone who really makes them feel seen and heard about these symptoms, which are very real. And sometimes we think, oh my God, it's just in my head. I'm going crazy. I have no idea what's happening to me. And, I feel my skin is itching, my joints hurt, my heart is palpitating. Again, if women don't know that these are symptoms that happen as we go through this transition, it can be very, very difficult. And so finding someone who knows and says, oh yes, that we understand, we totally hear you and see that that's happening to you. Here's what you can do to combat that is so important.
Yeah, it's that individualized approach that we really try to emphasize. And you just mentioned that something that reminded me of brain fog as a symptom.
Yeah.
So many people have brain fog and they really fear that they're losing their minds. And nobody wants to talk about that because who can work and feel that way? And even among their friends and family, I think it's very hard to articulate. So it's really, that's one thing that I feel so passionate about because estrogen can help these symptoms.
Yes.
So sometimes we offer a trial of medication if there's no contraindication to see if they're positive, if they have benefit.
Yeah.
And it's up to the individual if they want to go down that path or not.
Yeah. And so so that's interesting. So I always think about estrogen as managing the vasomotor symptoms, or the urinary symptoms. So either hot flashes, night sweats, or, again, having issues with painful sex or vaginal dryness or things like that. For those things, and I know for anxiety and things like that, like you said, that's where we can go to the SSRIs or SRIs and deal with other things that also might have a benefit for the hot flashes, et cetera. But when it comes to like brain fog and that, is that something that actually estrogen does help with?
Yes, it does. It's not FDA approved, but we do see an improvement in the brain fog. And whether it's related to like the night sweats that are, causing sleep disruption that then leads to brain fog. We don't know the answer to that yet.
Interesting.
So it's interesting.
And that's so much we don't know yet.
Yeah. And also in the perimenopause, the late perimenopause and early postmenopause, we see a lot of anxiety and we see estrogen sometimes helping for anxiety as well, at least in that window. There's many, everyone's a little bit different in how they come in.
Yeah.
And in how they want to engage with us. So, we'll really offer not only medications, but one of the other things our program offers that I just like to talk about for a second is we have these programs based in mindfulness. So we have a series of weekly sessions that are mindfulness based that deal with the symptom of menopause every week. So small groups get together and they're run in collaboration with our integrative health and wellness group here at NYU. And so they're run by one of the nurses from that center. And they just delve into a symptom and, they really form like a lovely community. So much so that from our first group, they continue to meet even after the 6-week sessions were over.
That's great.
Yeah. So it's up there. And I think that's part of the process is kind of sharing the experience and learning from people in your same almost cohort to normalize the experience. And I think it makes it a little bit easier.
Well, that's so interesting because one, I love the integrative care aspect of it. And like you talked about hypnosis as an option. And again, these other therapies that people don't maybe consider. And I do acupuncture for another autoimmune disease. And I love the approach of Eastern medicine in that the body is an ecosystem. And when one piece of the ecosystem is having some kind of issue, it really impacts the rest of the ecosystem. And that's very much seems like the direction we're not going in Eastern medicine, but Western medicine is about you're a robot and this part is broken and you fix it versus, it might have an implication somewhere else. And so when you talk about these practices and this opportunity to look at care across the whole spectrum of what's happening to the human is so important. And I really love that your practice and that others are coming to that conclusion on, there are other things happening. And then specifically about your group therapy and discussion, when I launched the National Menopause Foundation, we did a survey asking women what they wanted. And one of the things they asked for was peer-to-peer support, an opportunity to kind of bring that together. And so there is that need, and it's wonderful that you provide that. We have an online version, the Menopause Metamorphosis, which women can sign up for free and anonymously to do that. But it is part of wellness. It is part of treatment. It really is, in being able to have that kind of support.
Yeah, to find your community. I totally agree.
Yeah, it's wonderful that you're doing this. So we've talked a little bit again about how your practice works and what people come to you and ask questions about, et cetera. So when they come into the center, then how is it structured for you to refer people to the other departments that they might need to address some of their other symptoms with? Is that done all through your department? Is it done through the hospital system? How does that work?
Yeah, so our intake consists of the patients completing a scale. So a symptom scale, so that we have a baseline of how they're doing. And then we've identified areas that we want to kind of refer them to, or areas that we think would benefit for, if they've interacted with, like we were working with an exercise physiologist now and a nutritionist now, so we'll kind of see what they need, or whether psychotherapy or therapy support. So we identify what we can offer, and then we just make referrals out to these other groups. And we'll do it through either, everyone has the phone numbers of each other, and we kind of leave it in there, put the ball in their court for the most part for them to pursue. We also like to have follow-up within a few months so that we can see that things are progressing and see what worked and what didn't work, and offer, because there's always a plan B and then there's a plan C, and it doesn't always work, so we want to know what's happening, how come this didn't work? How come that didn't work? And if it worked a little bit, how can we tweak it to make it better? So we layer therapies and kind of layer resources, and just keep providing kind of like a scaffolding. So through this transition, so that on the other side, they're going to feel more, not regretful, right? More empowered, I guess, as they're moving into the next stage of life. We also really talk about the kind of underlying changes that are happening, both bone changes that are happening, cardiac change risk really starts to accelerate here. So we talk a lot about that. Changes in the vagina, with genital urinary syndrome of menopause. That's a huge topic, just to be sure that everyone's you're moving in the right direction, and you're aware of these things that change. We look at family history and assess for what might be specific to their risk.
Yeah. So do you have advice then for women who don't have a menopause center like there is at NYU? And I shared, we also, there's some around in Baltimore, and there's in California and different areas. But for the woman who's going to their either primary care or their OBGYN and wants to talk about these different types of care. So like I said, there's one addressing symptoms, but how would they even initiate the conversation around, I'm concerned about weight and I want to see a dietitian, or I feel like I need some therapy help? How would you recommend a woman? Again, we've already established schedule a separate appointment, but how should they ask about that integrative type of care when that's not an integrative practice?
That's really challenging. I think keeping, like we talked about, keeping a journal of symptoms, and maybe having 3 things that are really important for them to leave with some kind of resolution or a plan for resolution, and then making a follow-up, because I think patients really have to advocate for themselves. And we're in a system where our care is really fragmented, and, as practitioners, we're often siloed so that we aren't talking to each other. Yeah. So it does fall on the patient, unfortunately, unless they have someone kind of guiding them through it, like a, shepherd to figure out how to go to the next stop.
Yeah.
So I think there, maybe have 3 things they would like to accomplish, and then make a follow-up after that and say, I'm coming back.
Good.
To really, to be their own advocate.
That's great. That's great advice. Like I said, it doesn't have to be one and done either. Just even if you're initiated on any type of therapy or referral, you can go back and say it's working for me or it's not working for me.
Right.
That is really great advice. I love to be able to try to remind women that it is upon us to be an advocate for ourselves. And it was interesting. One of the things that came out of a recent summit we did, one of the comments that I loved was, if our child had a hot flash and then it happened again and it happened again and they were, embarrassed at school by what they were experiencing or whatever, we would be all over getting that child relief from that symptom.
Nonstop.
And then as women for ourselves, we don't. So it is sort of thinking of that, like when you think about, I don't want to advocate for myself, we would do it for our parents. We would do it for our children. And so staying on top of this and sort of saying, hey, this is not satisfactory. We need to kind of get a resolution to this. Try to be mindful of like, what would I do if this were happening to my child or my parent? And then put that same type of level of effort into getting it resolved for yourself. And wonderful again. Right. Wonderful to have experts like you available to support women and to help change the dynamic within the health system about, this is really an important time of life that we need to focus on. And so we're so grateful that you take that time and that you're available to women. We are going to make sure that with the episode, have the notes will have a link to where people can find more information about your program and the work that you do. And if they're not in that area, hopefully it will inspire them to look for that type of care wherever they are. And again, to go to the Menopause Society at menopause.org to get a list of providers who are specifically trained in managing menopausal symptoms. Thank you so much, Dr. Dunham, for sharing your expertise with us. We're really delighted to speak with you. Thank you so much. For those of you listening, I hope you enjoyed this episode as much as I have. And if so, please subscribe to The Positive Pause so you never miss an episode. And please share it with the people in your life who need to hear about this important stage of life as well. Thanks again to my guest, Dr. Samantha Dunham, co-director of the Center for Midlife Health and Menopause at NYU Langone Health. And thank you for listening. We hope you'll tune in to another episode of The Positive Pause.